From Walden Behavioral Care. Dr. Kate Craigen is the Clinical Director of Binge Eating and Bariatric Support Services. She is responsible for the clinical development and consistent implementation of binge eating disorder programming across Walden's inpatient, residential, partial hospitalization, intensive outpatient, and outpatient levels. Additionally, Dr. Craigen collaborates with various bariatric providers and partners throughout New England, ensuring both pre- and post-bariatric surgery patients gain the proper behavioral skills to enhance long-term outcomes. She completed her doctorate in clinical psychology at Fairleigh Dickinson University in New Jersey and her postdoctoral training at the Mount Sinai Eating and Weight Disorders Program in New York City. Meg Salvia is a dietitian at Walden Behavioral Care's Peabody Clinic. She sees adolescents and adults in the partial hospitalization program as well as in the binge eating intensive outpatient program. She is also a certified diabetes educator. She began her career working in research at Joslin Diabetes Center and joined Walden Behavioral Care's team in 2013. Meg earned a master's degree in nutrition from Boston University. Please welcome Kate and Meg.
Am I green? You are. Excellent. Hi guys, thanks so much for being here. Meg and I are really excited to be here. So we're going to be discussing, a sort of passion of ours, this overlap between binge eating behavior and the bariatric surgery population. We're going to start by going over the diagnostic criteria for binge eating disorder and some important points of clinical presentation. And then we're going to move into both the pre-surgery and post-operative considerations that we think are important for you guys to be aware of with this population. We've pulled together a handful of unique challenges that we often confront with this population. And then at the end, Meg and I have prepared a few case studies, but in general, we'd love to hear about any cases that you guys have questions about, so we're going to leave time to answer as many of those as possible at the end. So to start with, binge eating disorder recently made it into the diagnostic manual in 2013. The first criterion is recurrent binge eating episodes. Episodes have two major qualities. One is eating in a discrete period of time, usually 2 hours or less, an amount of food that is unusually large. So we're not talking necessarily about the unusually large amounts of food at Thanksgiving or at birthday parties, but this would be unusual for the person themselves, and definitely larger than what most people would eat under similar circumstances. And then the other piece of a binge eating episode is a sense of lack of control during the eating episode. I would say that within the field there is some difficulty really identifying what an unusually large amount of food is. So I would say that the feature to really pay even more attention to is that loss of control over eating during a binge eating episode. The episode itself has to have 3 or more of the following, though we often see people who endorse all of these features: eating more rapidly than they usually would, eating until they feel physically sick or uncomfortably full. These episodes are rarely tied to hunger cues and often lead to isolation due to embarrassment about the behavior or fear of engaging in the behavior around others, and often feelings of disgust, guilt, or depression that come up afterwards, though sometimes those emotions and feelings can emerge during the episode. There has to be marked distress. The frequency criterion is that these eating episodes have to occur at least once a week for the past 3 months, and you cannot meet at the same time diagnostic criteria for anorexia or bulimia nervosa. So these are people who, the binge eating and the definition of binge eating episodes would be the same for bulimia nervosa, but we don't have any compensatory behaviors following the eating episode. So I wanted to go into a little bit more detail based on, my clinical experience with the population on what a binge eating episode is really like for these patients. They describe not being able to stop eating once they have started, and potentially not even being able to control what they are choosing during the episodes. People talk about eating foods that they don't particularly like or that they would not eat if it was not binge eating. There is an out-of-body experience that's sometimes reported. really people feeling almost like they're sort of watching themselves, wishing that they could stop and being unable to. A typical binge eating episode has between 1,000 and 2,000 calories, but about a quarter of the episodes that are reported to us have more than 2,000 calories in them. And the types of food really do vary quite a bit. So one of the hallmarks is certainly the foods that people are trying to avoid. We know that those show up in binge eating episodes. And sometimes the binge eating foods are sort of they go along with whatever the fad diet is of the time, right? So if it's sugar that is the enemy, then oftentimes the binge eating episodes have sugar. If it's carbs that are the enemy, right? It can sort of vary with the sort of fad diet of the decade. And we know that there are a few common triggers. So that one that I just mentioned, dietary restraint, the kinds of foods that people are trying to avoid, being in the presence then of those foods, or after a long period of time of restricting yourself from those foods. We know that certainly interpersonal stressors and conflicts can lead people to engage in binge eating. We know that any negative experiences around shape, weight, food, eating, these things that sort of elicit some of potentially that negative body image are certainly big triggers. And boredom, actually. A lot of our patients will describe kind of being at home or not having a lot to do and engaging in these behaviors. I want to just distinguish binge eating from a few other types of eating episodes. In general, we will have patients come in using any of this terminology to describe what's going on for them. I don't necessarily get into like a semantic sort of, discussion or argument with the patients, but in terms of the way that we think about different eating episodes and probably the way that you guys think about them, I just wanted to distinguish them. So emotional eating is typically going to be those eating episodes where the patient really notices some sort of shift in their emotional state. I would say that this is not an unusual type of eating episode. We all, if anybody can sort of think of a comfort food, right? Like technically that counts as emotional eating. This happens to most people. Grazing is really that sort of eating smaller amounts of food constantly throughout the day. Night eating would count as, we would consider it anything that sort of is eaten after the evening meal or in the middle of the night. So the diagnosis of night eating syndrome, which right now falls under this sort of other category in the DSM, night eating syndrome requires at least a quarter greater than a quarter of the total intake in the day to happen after that last meal of the day. And then generally sort of overeating. This is a tough one because it's really quite a subjective label, right? Sometimes it has to do with physical sensations. Sometimes it has to do more with really judgments, comparisons to others or what other people are eating, and judgments that people make about themselves with the degree to how much they have consumed. So overeating episodes and the rest of these eating episodes up here do not inherently have the loss of control component that a binge eating episode does. So I wanted to define, just kind of pull out, I mentioned that the loss of control part of the criteria for a binge eating episode is kind of potentially the more important one. It is more consistently present for all binge eating episodes. But we also have people who report just loss of control eating. So that quantity criterion is not there. And certainly post-bariatric surgery, we hear a lot about these loss of control eating episodes. And because the patient is not physically able to consume a large amount of food, this is kind of the manifestation of binge eating, or the version of binge eating that you're likely to sort of hear about and be assessing for in the sort of, I would say, the time fairly recently after surgery, when the physical amount that people are able to consume is so limited. So during loss of control, no matter how much is consumed, there are those same feelings. Like they cannot stop eating until they feel physically sick or uncomfortable, and choosing foods that they maybe do not want or do not like. So all of those other components are still involved in a loss of control eating episode. So some common features to people presenting with binge eating disorder. There's the other psychiatric comorbidities that are most common, though we see others, are anxiety, depressed mood, and substance use disorders. Certainly the substance use disorders has that sort of impulsive feel to it in the way that the binge eating behaviors do. There are not actually medical comorbidities that necessarily commonly occur with binge eating disorder. However, when weight gain is secondary to the binge eating behavior, then you have the medical comorbidities that are really sort of associated with weight, like diabetes, hypertension, and some of the other sort of really weight-related medical problems. Oftentimes when these patients present to your office, they will report current or history of very chaotic eating patterns, potentially having tried a number of sort of fad diets, going long periods of time without eating, cutting certain foods out of their diet. There's often been many different attempts to shift or change their eating patterns in some way to affect the frequency of the binge eating, rarely successfully in the long term. We know that these patients present to us sometimes on an average of after 10 years of having struggled with binge eating. So there are numerous different possible reasons for this, but we know that a lot of people try to control their eating via sort of weight loss programs. And there's a belief that that really what they're struggling with is sort of a lack of willpower or not having enough sort of like strength of character to be able to maintain, right, or control behavior. And usually it takes a long time for people to kind of get to the point where they have tried so many things and they have been unsuccessful that they recognize sort of needing help. Certainly something that also might, contribute to the long length of time before we get to work with them is just lack of awareness that binge eating disorder exists, right? That it is an eating disorder and it's not just a matter of, of willpower. This population tends to be highly self-critical. Sometimes those experiences with kind of like yo-yo weight loss or, success, quote unquote success and then failure with diet programs leads to a sense of very low self-efficacy. And all of that contributes to pretty significant feelings of shame, feeling bad about who they are as a person, and guilt, really feeling bad about their own behavior and the choices that they make. We'll talk a little bit more about the role of shame and guilt and how that can play out clinically a little bit later in the presentation. And one of the things that people tend to overlook with binge eating disorder is a significant amount of psychosocial impairment. So when I say this, I'm talking about the eating that happens in the evenings that leads people to not sleep very well and then not be able to function so well the next day at work. I'm talking about the economic and financial burden of purchasing food for binge eating. It can be quite expensive, in fact, and have an effect, on your individual or family's financial situation. And certainly the psychosocial piece of relationships and interactions with others, right? If these episodes lead to isolation and sort of withdrawal from society because of fear of engaging in binge eating, that's going to have obvious effects on how you are able to function in your relationships. So I just wanted to highlight some of these facts that come out of the 2012 World Health Organization data collection from internationally, but I pulled kind of just the US data to show you guys. So it would seem that somewhere around 2.6% of adults in the United States struggle with binge eating disorder. In compared to other eating disorder diagnoses, this one affects both men and women in a more equal way. Certainly with the other eating disorder diagnoses, we see that there seems to be a gender effect for female. Again, the World Health Organization only collected gender in a very binary way, so that's kind of the data that we have on this, but around 4 million women and 2 million men struggle with binge eating. The disorder does not seem to discriminate based on income or race. We see binge eating disorder everywhere. We see it in all different types of countries of different socioeconomic sort of levels. We do know that the onset is usually late 20s, so a little bit later than some of the other eating disorder diagnoses. But people also report having engaged in binge eating for as long as they can remember. So for a lot of people, it does kind of go all the way back to childhood. And there's a couple other times that are high risk. We know that going off to college seems to be sort of a high risk time, that really significant shift and change in the dining options, right? To go from being at home and having one option usually to being in a college or university setting where the access to food is very, very different and changed. And for some women, pregnancy is actually also a high risk onset time. The other point that I wanted to make is just the sort of top right box, that with binge eating disorder, like other eating disorders, you cannot necessarily see it or observe it externally. World Health Organization found that 55% of the people struggling with binge eating disorder actually fall into that BMI, quote, normal weight range. 45 into the overweight or obese category. So I think that there is kind of a misnomer that body size is going to reveal in some way this particular eating disorder, and that is very much not the case. So luckily, we have a number of different treatment options for binge eating disorder. There are self-help options that have good research behind them, psychotherapeutic, mental health interventions, specific nutrition counseling interventions, which Meg is going to talk a lot more about, and we also have medication interventions. So in general, this emphasizes the importance of a multidisciplinary approach to the treatment of binge eating, and the more of these sort of different specialties that we can have involved, the better. So I wanted to give you a little bit of data on binge eating disorder and bariatric surgery. There is a pretty significant frequency of binge eating disorder in individuals with obesity. So the data ranges from around 3 to 5%. If we look at the category, if we look at all the patients presenting for bariatric surgery, pre-surgery, there's not a significant difference in weight status between those with and without binge eating disorder. However, people who meet criteria for obesity and binge eating disorder tend to actually have a very complex and more serious psychiatric sort of profile. So more psychosocial problems, more likely to meet diagnosis for other psychiatric issues. So they're going to be a more complex population of those patients presenting for surgery. The data on the prevalence of binge eating disorder, just loss of control eating and night eating syndrome, ranges quite a bit in the data that exists here. I think that's probably a result of lots of different things, but the methods for assessing for binge eating disorder, loss of control, and night eating, I think varied between the studies cited here. I also think that there's a lot of shame and guilt that leads to hiding of these behaviors in the context of an assessment pre-surgery, but up to 30% of their patients presenting for bariatric surgery could be struggling with what we would diagnose as binge eating disorder. Up to 60% have that loss of control eating. Sometimes people call it compulsive eating. It doesn't necessarily have the quantity piece, but that sort of not wanting to eat it and eating it anyways feature. And then night eating syndrome, so more than a quarter of your total food intake after the last meal, could be up to 17%.
All right, can you all hear me? Good morning. Everyone here is a dietitian, right? Yeah, I'm happy to be with my people. I'm a dietitian too. So what I wanted to do with some of the in-visit, in-conversation information that I'm going to talk about is share what I've learned through my years working with clients with eating disorders and co-occurring conditions like diabetes, or those who are looking to pursue something like weight loss surgery or have had a history of weight loss surgery and are continuing to struggle. So that thought is like, what goes on in my conversation and what nuggets can I give to you guys so that it feels more comfortable to have these conversations? How many people feel like they've had a counseling session or have worked with a client who's experienced binge eating disorder and haven't labeled it as binge eating? So some question marks there. How many people feel like they've worked with a client where it was like problem list, the diagnosis codes, binge eating disorder right there? A little bit less often, but still some good. So it's a pretty new diagnosis, so we might be seeing this happening more and more, but I still want to leave it wide open that our space, the conversations that we have with our clients, might be where some of this starts to percolate up to the surface, and we might be recognizing it because we have more time, we have more space, we have the skill set, hopefully, to bring some of these conversations out and to be a safe space for the client to talk about it. So when we don't see that diagnosis code right there and we're trying to understand, are we talking about binge eating disorder? Are we talking about loss of control eating? What I want to do is go through a couple of questions or a couple of ideas about how to kind of clarify what might be going on for the client. I want to say sometimes when we feel like we're about to engage in a conversation about eating disorders, it can feel like a lot of anxiety. It can be really tense, or we can feel like I don't know what to say, or I want to say the thing that's going to make it better, it's going to fix it really quickly. So what I want to do is when you feel that kind of tension rising up in your chest in conversation with the client, breathe and try to welcome the conversation as open, relaxed, curious, because I don't have a single sentence that resolves this for my clients. It really is relational. It really is making my visits with them a space where they can talk about something that's so infused with shame and stigma and emotion that it feels hard to talk about it with their families or friends or other treatment providers. So in that moment when we feel charged and anxious, breathe, because our clients are also feeling charged and anxious. Right now, in a moment where I'm talking to a room full of people, breathe, because that can help reduce that kind of amped up feeling. Okay. So, as Kate was talking about some of the, is this a pointer?
Sideways.
Yes, okay. As Kate was talking about the two features, and remember what they were? Objectively large quantities of food and that hallmark feeling of loss of control. So these are, you can't see the red dot when I point it, can you? Okay. So the quantity here, some questions to ask are about how often do you think you eat more than usual or more than what other people would eat in a similar situation? I'm going to mirror what Kate said though, in that sometimes the quantity picture is a little bit hard to talk about as the first thing. For one thing, our clients have a sense that they're always eating too much. So the sense of like, I'm trying to lose weight, everything I eat isn't okay. So it's hard for them to assess like what is a normalized portion. I get a lot of questions around what does normalized eating look like? What is too much? So that can be a little bit of an obscured question to ask. The other thing is that sometimes talking about that sense of loss of control is more helpful than actually knowing what the content of a binge is. So the actual binge behavior patterns, again, are so associated with shame and a sense of embarrassment that our clients might actually not want to tell us what they ate. And so I want to give a little bit of space for us not needing to know all of that detail. Do we need to know if it was 2 boxes of Oreos or 1? Do we need to know if it was 3 Big Macs or 2? Not really, just that I binged and it was my usual pattern of going to the drive-thru. Again, this is a very iterative conversation, so we can add more details, we can add more question, we can add more curiosity and get more information through each conversation. But if someone is starting to open up and tell you about their eating patterns or to tell you about their concerns, I would just put that on the back burner, that if we go in with a lot of questions about, well, tell me exactly what you ate, tell me the quantities, tell me the details. Yes, that information is really helpful for us, but it's not always really helpful for them to go over right out the gate. So we can get there, we can have some time. It is helpful to know like what are the kinds of foods that are involved in these behavior patterns. So is it sweet, is it salty, is it crunchy, is it part of a ritual where you go out and go to the drive-thru or you go to the grocery store and get this and then this and then this. So some of that information gathering can be helpful, but give yourself some space to not need to know all of that right out of the right off the bat. Okay. These bullet points here mirror some of what Kate was talking about in terms of eating foods that you don't even like. So sometimes when a client is talking about binge behaviors, they'll be like, and this is so weird, like it's not even a favorite food, or it can feel like it's, there's a sense that we're eating whatever is available. So sometimes, like an instance that I can remember was eating a large amount of sweet potatoes. And there was a lot of confusion, like why was the sweet potatoes the choice? I don't even like that food. But there was that loss of control. It didn't matter what the food is to some extent. Okay. So these are some questions that I really like to ask in session with a client, and these are questions that you might find helpful to pull one or two if you start to notice this pattern coming up. How did you notice, or do you notice that you try to isolate during those times of episodes? So that means that rather than having this be a social setting, there's a routine. There's an eating the food and then withdrawing from the social supports. Do you eat more when you're alone than with other people? This is my favorite question to ask in an outpatient setting where it's not just an eating disorder focus, because this can really open up the door to what does eating patterns look like and what feels secretive or shameful about those eating patterns. That's not to say that binge behaviors happen when we're alone and just alone. So sometimes people will feel like I was with a group of colleagues and that situation was so intense that I engaged in behaviors there in the middle and it was really embarrassing, or I was feeling really intense in the moment and felt like I wanted to leave the situation and go get some of my binge foods and engage in behaviors at that point. Do you eat more rapidly than usual? Pace is a really present, or a quick pace is a really present feature that I see a lot of the times, and it's sometimes what contributes to that feeling of discomfort or the sense that we're eating more than our bodies can handle comfortably, and it's happening on a faster timeline. So pace is a really good thing to start to get curious around, even as we're leaving some space for not knowing exactly what the quantity looks like. Do you eat even though you don't feel hungry, and do you ever eat until you feel physically sick? What ends the binge behavior? What ends the binge episode? A lot of times I'll hear, I eat until everything is gone, or I eat until I'm so physically unwell that I can't keep going anymore. So why would this be an issue? How do we start to have these conversations? Why would you, as dietitians who work with clients considering weight loss surgery or having had weight loss surgery, be seeing these? So sometimes the binge patterns will come up because we're on that track of wanting to achieve certain outcomes getting ready for surgery. And we're not seeing things like the recommended eating pattern being followed, or it's feeling like there's a question mark of like, something's not shifting the needle, what's going on? It can be a helpful way of saying, what is going on? Again, the client can feel very black and white in terms of failure and success. So if that conversation around, are we in a stuck place? Yes, we can be in a stuck place in terms of the body's changes and metabolic plateaus, but we can also be in a stuck place because stuff is going on that we don't feel comfortable talking about. So again, having the dietitian's office being a safe space to talk about any and all eating behaviors is the most important thing. So what we would do is, if we think that binge eating is going on before surgery, we could refer to an eating disorder specialist team to help unpack the eating disorder behaviors before pursuing the pre-surgical trajectory or the pre-surgical pathway. So it's kind of like calling a timeout. Let's focus on this and then revamp and resume as we feel appropriate or as we learn more about what's going on. One of the patterns that I see so often, I cannot stress this enough, is this thought of ideal or on-track eating in the beginning part of the day and binging later in the day. How often do we see that? Like breakfast and lunch went okay, and then I seem to, I fell off the bandwagon, is a phrase that I hear a lot of the time in the afternoon. What's going on? So if you see that pattern, have your red flags up or have your radar up for wondering, is there binge behavior going on? Our clients can have a lot of thinking around I'm eating perfectly at breakfast, I'm eating perfectly at lunch, and then I'll talk about this a little bit more later on, but the two things that tend to happen, one is that those 2 meals are so inadequate in terms of nutrition and nourishment that frank hunger breaks through, or we're transitioning. So it's something like I'm commuting home and all of a sudden the quietness of my house is a very stark difference to the hustle and bustle of the office. Or I'm in my car and I'm driving, I drive down Route 1 all the time. So anyone who's in Massachusetts, you might know that. And I see the sign, and it's like that transition and that signal and that sign just switches a flip. So the two things that I see a lot in that vulnerable transitional period is either the biological metabolic hunger or the vulnerability of some of that that boredom, that loneliness coming in. I know what I need to do, I just need to do it. How often do we hear that one? All of the time. So that phrase to me is one of those situations where it's like, okay, take off my dietitian hat of like wanting to provide the solution. Let's brainstorm some strategies. Let's do some motivational interviewing and see like what's going on. That's an invitation to be curious and to slow down. Tell me a little bit more about your day. Tell me a little bit more about your eating patterns. Tell me a little bit more about what you perceive are the barriers. Because sometimes this, to be honest, feels like a way of saying, I hear you, dietitian, but I'm gonna stop talking. So if we can say, okay, I hear you, tell me more. I'm curious versus educating or versus lecturing, or not that any of you lecture, but like, let the flow of information go the other way. Does that make sense? Yeah, okay. All right. And the other thing that I'll see, and you might see this as well, and so have your antenna up for this, is if people feel like weight loss surgery is my last option. So sometimes I work with clients who hope like if I get weight loss surgery, that's going to fix things with my nervous system or hormones or the literal anatomy, and it's going to make things not feel, I'm not going to be as hungry anymore, or it's going to shift things and my stomach size literally won't accommodate a binge. Kate was really eloquent in talking about like, yeah, so sometimes our anatomy is altered and that volume, that objectively large quantity of food isn't possible anymore, but that loss of control and that guilt and that shame are still very present. And so having our eyes open around if a concern for binge eating is driving the surgery and how they feel about that. So opening up the space to be vulnerable with the client around that. I'm gonna cough 1 second. Sorry, was that really loud? Doing okay? Okay. One of the things that I like to point out is that binge eating disorder and the treatment of eating disorders is one of those psychological diagnoses that has recovery. So I love that about my job. So sometimes with some of the overwhelming diagnoses that our clients can get, it feels like, oh my goodness, what are we gonna do? But with eating disorders, recovery is possible. So I want to let you know that it's infinitely, abundantly possible. Not everyone achieves that right out the gate, so I do want to leave space for those who struggle or who need repeated admissions or who have a window of absence of behaviors and then fall back on behaviors when they need to or when things get a little bit difficult. I had one client who went through our binge program and loved it and went on to have a really smooth post-discharge transition. And then she got divorced and her dad died in 1 month and she came back and she's like, why is this happening again? And it's like, well, that was a really intense month. So recovery is possible, but sometimes repeated episodes of treatment may be utilized. But that's where it can be really helpful to say, if we think binging is going on, let's work on that. Let's get treatment for it because we really can treat it.
Okay. So oftentimes you guys are involved in some of the decisions about whether or not it is appropriate to sort of pass someone through for approval for surgery. And I wanted to give you some information on the current data that we have, the current research to support some of these decisions. Clearly your patients are also getting a psychosocial eval with a mental health professional, and that eval and those recommendations have a lot to do with it. But I wanted to distinguish, we have some data, and if you could just help me click through. No, that would be great. I'm gonna just keep going. The binge eating disorder diagnosis versus there are studies who assess loss of control eating, that just the control component, not the quantity. So I want to distinguish those things and give you some sense of what we know pre and post surgery with regard to risk and with regard to the potential to impact surgical outcomes. So studies that relate pre-surgery binge eating and binge eating disorder with weight loss surgery outcomes have pretty mixed findings when it comes to binge eating disorder being associated with poorer weight loss outcomes. So some studies find that it is associated, some studies find that it is not. I would say that typically those with shorter follow-ups, the research studies who are tracking patients 12 and 24 months out, find that there is rarely a recurrence of binge eating within that period of time. And it may be more likely that some of the longer term studies or the 7 and 10-year studies are finding that the loss of control eating or the binge eating behavior will kind of creep back in for those patients who were experiencing it pre-surgery. But variability in these findings, it's likely related to all different kinds of things, right? Study quality, the methodology, which outcome, which post-surgery outcome people are actually looking at, and how they're defining sort of success. So when it comes to the assessment of just loss of control eating, the data suggests that if you have a patient who's experiencing loss of control eating pre-surgery, it is predictive of them experiencing loss of control eating post-surgery. So again, kind of like what is possible with the binge eating behavior or binge eating disorder, it may be less present right after surgery and then become sort of more frequent or more prevalent a little bit farther out from surgery. We also, so interestingly, for those patients who do have the pre-surgery loss of control eating, there is not consistent data to say that that is going to predict weight loss outcomes. Just important to keep in mind, right? So loss of control eating pre that predicts post doesn't actually necessarily translate to poorer weight loss outcomes post-surgery. However, we do know that at post-assessments, so when you guys are following up with patients afterwards, when there is loss of control eating, it's more likely to affect weight loss. So this is just these little sort of, things that are important to kind of distinguish in the research, that when this behavior comes up post-surgery, and for some people, it will not have been there pre-surgery, right? Or it was not reported pre-surgery, but now in the follow-up, they're starting to report it. Those patients are likely to have slightly less successful weight loss outcomes than people who do not report post-surgery loss of control eating. So this is a little confusing. So we can go back to this and go through it all. Certainly another finding with that post-surgery loss of control eating is greater weight regain. Sort of after weight loss plateaus, they may be more likely to gain more weight after surgery. And in general, when we come back to there's been a few studies that really assessed binge eating in response to these sort of negative emotional states. Not all studies assessed that specifically, but there's a lot of different triggers and reasons for binge eating. But for those people who really identified that there's a strong emotional component, those patients tend to have poorer weight loss outcomes post-surgery. But the data, I would say, highlights the importance of the assessment of eating behaviors both pre and post-surgery. And that's kind of what Meg was just walking you through, some of the ways to sort of get at the presence or absence of these behaviors. But essentially, it does really kind of highlight that the loss of control component is really the important part of the binge eating episode, right? That loss of control is likely to affect the outcomes that you guys are supporting your patients and working towards. So I would say that this data suggests there's a lot of reason to be sure that you are assessing for loss of control eating in that post-surgery time, the follow-up, because certainly we know that's going to affect outcomes. But this data doesn't actually sort of say that if you have binge eating disorder pre-surgery, you are going to have binge eating disorder post-surgery. It does not say definitively that if you have it pre-surgery, you are going to have poor weight loss outcomes post-surgery. So for me, I often do the psychosocial assessment for surgery. This is not one of those red flag rule outs for surgery. It's not, right? The benefits of surgery outweigh the data that we currently have with regard to how binge eating disorder predicts those outcomes post-surgery. So just so you know, it's not necessarily going to prevent someone from that clearance to pursue surgery.
Okay, so where we are right now is we're talking about what we do when we identify binge eating patterns before surgery occurs and implementing the nutrition treatment for binge eating to help reduce the frequency of behaviors or the quantity of behaviors. So it's kind of like we're in that timeout space of like, we know that this is happening, let's see if we can help resolve or bring some resolution to this before we progress. So we're in the pre-surgical phase. This is what a snapshot of our eating pattern looks like. So when I work with clients in program, they're coming to a structured 3 days a week program and they get an eating pattern or an eating plan. We ask clients to sign an authorization to collaborate with outpatient dietitians. So I do work closely if they have a bariatric team in place. But we start from a place of structure. What might structure look like? Kind of ballpark. What are some of the keys that we're looking for? Time of day? What do you mean? Say more about that. Yep. And so this is just one little snippet. Our eating pattern has structured eating opportunities throughout the day to kind of spread out that distribution. What else are we looking for? Say it again. Yes, that is a good point. I haven't captured that in an eating pattern. Like, so when I give them the guidelines for the structured meals and snacks, that is more of a conversational element. I haven't looped it into like, so, and I think too, part of what you're talking a little bit about is mindfulness eating. I will get more into that as well, but you're spot on, but I haven't found a way to integrate that into my written materials yet. The other thing that I'm talking about is having all of the food groups present. So this means having some starch, having some proteins, having some fats, fruits and vegetables, and some fluids. What we're trying to do is give clients enough feedback and enough information around what portions might or could look like, or how we might want to start experimenting with what is enough, what is too much, what is too little in order to meet needs, without saying eat exactly this and exactly this and exactly this. So we have an exchange list that gives a lot of options around like, what are we talking about when we talk about a starch? What are we talking about a protein when we talk about a protein? What are we talking about when we talk about a dietary fat? So a little bit of education built into that, but also helping to manage that sense of overwhelm when clients are like, what do I eat and how do I even know where to start to put this together? So trying to give some tools around answering those questions. The goal is adequacy. This might be blowing some of your minds, and for sure it blows my clients' minds. This isn't a weight loss specific meal plan. The goal is to provide enough nutrition, enough nourishment from different sources at different times of the day to interrupt the binge eating pattern. And it can feel like, but wait, I need to be eating less, like I need to be aggressively targeting weight loss right now, and that's where I feel that like heightening anxiety, and okay, what we want to do is press pause and interrupt the binging. Because remember what Kate was talking about, the quantity of binging is on the order of thousands of calories. So if we can reduce how frequently that's happening or how often that's happening, we are reducing intake and we're meeting nutrition needs. So it's a little bit of a mindset shift, and I have an image that I'll talk about when I explain that a little bit more. And then the goal is to eat every couple of hours. Again, coming back to that pattern that is a little bit of a red flag of like either skipping breakfast or eating a really like virtuous breakfast and a tiny, tiny lunch, and then eating a lot at the end of the day. What we want to do is spread that out a little bit more and eat at regular intervals so that urgent hunger isn't breaking through and compromising decision-making abilities. So, like I said, this blows some of my clients' mind. I want to allow for space that the eating pattern and the nutrition recommendations for treating binge eating disorder are likely going to look different from the nutrition plans that you're recommending for a pre-surgical pathway, right? Questions about that so far? I'm going to cough again, hold on. Sorry about that. So the goal, the big goal, the umbrella under which we are all operating is interrupting the eating disorder behaviors. So reducing the frequency and quantity of those like large, objectively large eating opportunities, challenging the rules from a scientific perspective. So many times I have clients coming in saying, I can do this and this part of the eating pattern, but I'm not allowed to eat starches right now. Or like Kate was talking about, our trends and our fads can cycle through foods that feel more off limits to clients than others. So it's introducing those foods, or at least those food groups initially, and helping the body get access to the nutrition that it needs. I had one client who came in and was like, I'm trying to follow these eating patterns that my family is recommending. Like their Facebook feed was full of recommendations. And they're like, my boyfriend really wants me to follow paleo, and my mom really wants me to do vegetarian. I'm having a really hard time doing both. Yes, that's really hard. So kind of giving some space for like, you don't need to listen to your Facebook feed. This is individualized nutrition recommendations. I am your dietitian. We are monitoring multiple components. We are going to make recommendations based on how your body is responding to treatment and adjust from there. So this eating pattern has a lot of flexibility in terms of the ranges. What we do is we start from kind of this square one, and we build up in terms of how does the client respond, what does their body need, can we add more details, add more information based on how the body is responding. So it really is individualized and adjusted. It's not set in stone. It's not like, here is your meal plan, hop to, get in line. It's more like, let's try this, let's see what's working, let's see what's not. We'll continue doing what's working, and we'll adjust the support around things that aren't working. So it's pretty fluid, and it's meant to be iterative. I'm learning about the client and their eating disorder as we have conversations. A big part is to diffuse the fear. So again, that idea of, can the dietitian session be one where there's curiosity, compassion, and openness versus judgment and some constriction around sharing what is actually going on with the eating pattern. Because when I talk about that structured eating pattern, there's a lot of fear on the client's behalf. There's a lot of thought of, if I change how I'm eating and I'm eating more earlier in the day, won't that mean I'm gaining weight? And isn't that the scariest thing? Like that feels like the worst thing to happen. And there's a little bit of a leap of faith. And so trust and openness are huge elements of the conversations that we have. And so again, coming back to the body's response, rooting our recommendations in the body's response. How does your client shift or respond to the recommendations that we're making? So these are the two images that I use a lot. Let me explain the first one, the standing on two legs. So our goal of adequate nutrition is meant to stand alongside the therapeutic intervention. So in program, they meet with a dietitian, they meet with a social worker or a therapist, and they're attending groups. And it's not enough for me to have a conversation about what the eating pattern looks like or the meal plan. They need that alongside of the stress tolerance conversations or the coping mechanisms that they're learning or the skills that they're building in group and in session with their clinician. So the idea is that we kind of have two legs. One is the therapy side and one is the nutrition side. And if we are doing therapy, but eating is so disordered or chaotic and there's no structure there or it's inadequate, this is going to be helpful but not as effective as if we're standing on two legs. Similarly, if we're having nutrition conversations and our clients aren't adequately supported therapeutically, we could make all the recommendations in the world and we're still going to run into issues of needing to help build up support around the motion regulation. And we don't always get that skill set or that toolkit from our classic educations. So I really like to have the two work in tandem. Excuse me. Similarly, when I was talking about that urgent hunger or that breakthrough hunger, if we are going through our day and we're eating that small breakfast or skipping breakfast and then that virtuous lunch, and we're experiencing that building hunger, that growing hunger. Maybe we're not getting subtle hunger cues anymore, but we're getting, like, our first sign of hunger is pain or nausea, or all of a sudden we're at like up to our eyeballs in hunger, or we reached our max. It's going to be really hard to lean on the skill set that we're learning therapeutically if we're also trying to manage hunger, that biological metabolic hunger. If we're driving down Route 1 and we see the signs and we're also hungry, it's going to be really hard to lean on the tools that we're learning with our clinician. So the two work together. The other thing that I talk about is interrupting a swinging pendulum. So restriction is usually part of the eating pattern. We talk a lot about binge eating and binge behaviors in that objectively large quantity. There's usually a component of restriction saying, I need to try to limit my intake either because I'm trying to lose weight, or I need to limit my intake because I'm predicting that a binge is going to happen later, and I need to make sure that the two eating opportunities or the amount of nutrition that's going in don't compound. So anticipating a binge means I'm not eating earlier. And the lived and learned experience of our clients is really that they're oscillating between this side of restriction, and then when they start to eat, it turns into a binge, and it feels like we're either in one extreme or the other. And what the eating pattern is trying to do is bring it to a calmer middle space. Same thoughts happen around weight. So I'm either actively trying to lose weight or I'm actively gaining weight. And that thought of adequacy and stabilization is actually a thought that doesn't get talked about all that often, or doesn't get thought about all that often, I find, in my clients' minds, in part because of that black and white thinking pattern, like I'm either actively losing, or I'm actively gaining, or I'm actively restricting, or I'm actively binging. But this thought of, okay, let's center and stabilize, and then move on from there. So this is the binge and restrict cycle. The two are often related. So the pattern that I see and that you might see in your offices is, I'm gonna cough again. Sorry about that. A pattern where in the far left corner, there's a binge episode. And after the binge episode, again, those thoughts of guilt and shame and remorse leading to resolve. So that diet's gonna start on Monday, or I need to try harder. Like Kate was talking about, it's not just a thought about willpower. It's much more than that. But the client's response is, I need to have more willpower to stop this from happening next time. So then they change eating patterns or attempt to change eating patterns to make up for the binge episode or to limit the foods on which they're binging, and that leads to that frank hunger again, and that leaves us vulnerable to binge eating. And the cycle kind of feeds in on itself or repeats itself. Okay, so adequacy is sometimes a thought or a component of the eating pattern that feels challenging for clients. The other thing that can feel really challenging is the fact that we include dessert in our eating pattern. And that is really difficult for a lot of the clients that I work with, in part because it feels like one of those foods that they should absolutely be avoiding. And these are foods that they often are actively binging on. So it can feel really uncomfortable to have a conversation about intentionally including this there. So we include the challenge foods or the exposure foods, or like we have dessert in program, but we also encourage people to do the challenges, exposures outside of program too. So something like chips or snacks or favorite foods that feel off limits. Why might we do this? Yeah. Absolutely. I really like to use the phrase like lived and learned experience, because our clients often have past episodes where when I eat that food, it leads to a binge. And so what we do in program is intentionally introduce that food and not binge afterwards. So it elicits a reaction, and we're not using an eating disorder behavior to manage that reaction. Kate's going to talk a little bit more about that in a minute, but the idea is that when we're avoiding a certain food, or when we feel like that food necessarily leads to this outcome of a binge and that's extremely uncomfortable, I need to avoid that food. And then that plugs us right back into that restriction resolve cycle, and that leaves us vulnerable to a binge, and then we're eating that food, and that reinforces how true it feels that I can't have that food. That food is off limits. A story that I like to tell is about Oreos. How many of our clients like Oreos? Some. I'm actually getting some raised hands and some like, And I like that response because that's actually the response of my clients is we have Oreos in our kitchen, and so if you don't bring a dessert, we'll ask you to plate some of the cookies that we have on hand. It's hard on day one, and then what happens is we sit with the Oreos. Sometimes there's tears, sometimes we're not able to finish it. We do it again, and what happens is Oreos become easy. Oreos become no big deal. And so clients who have binged on Oreos are like, I get to decide how I like Oreos. And that kind of, like some people are like, I don't even like this. Or it doesn't feel as charged, doesn't feel as dangerous. And then the conversation that we have is like, what would you like for dessert? Cookies, Oreos or good cookies? Because then the concept of what feels vulnerable to a binge shifts a little bit, and that's from that repeated exposure. So the idea is that we're learning that experience of this is what it feels like to have Oreos and to have it not lead to a binge. This is what it feels like to have cookies in a pattern or in a portion that doesn't feel out of control. This is what it feels like to have that experience and to have your body respond.
So we thought we would explain kind of how this works, and in truth, the idea of exposure is a well-studied, well-validated psychological intervention to address anxiety, distress. We know that avoidance of certain things increases our tendency to think about those things and be preoccupied by those things. I want to highlight, Meg and I want to highlight that we recognize that as someone is working towards surgery and post-surgery, there are obviously things and foods that they must avoid, right? Some that's going to be sort of part of the plan if there's a weight loss plan pre-surgery, or the just nutritional needs and the things that they have to focus more on and the foods that they have to stay away from. And so we know that this is part of the surgical plan pre and post, but when someone is struggling with binge eating disorder, this stuff has to really kind of be addressed in one way or another. We can do it pre-surgery or we can do it post, but what we are seeking to do is actually take power away from those foods. So when you avoid things, and this is the case for avoidance of all kinds of things, not just food, but when you avoid them, the power and control that they have over your life increases. So in this example, right, if you have anxiety about sweets, and we go with dessert because it tends to be one of the things that's most difficult for the binge eating disorder population we work with, over time, with avoidance, the anxiety will increase. So in this sort of example, it's like maybe you have a niece's birthday party that you're invited to. You know there's going to be goodies at the party. You make up some excuse or some reason, maybe your car broke down, you didn't make it to the party, right? In the immediate short term, your anxiety will go down. You're not going to be exposed to those sweets. You're not going to be around them. It's a group setting, so you were nervous about binge eating those foods in the first place. So your anxiety will decrease in the short term in response to avoidance of that party. But there's more parties in life. And the next one is maybe a work event. It's a holiday, right? And somebody brings a cake into work. At like 4:30, everybody's kind of gathering in the kitchen to sort of partake in the celebration. And again, like your anxiety starts to go up. It's going to be higher next time than it was the first time, right? Because you're still fearful and you believe that avoidance is the only way to sort of manage that distress and to prevent yourself from whatever reaction it is, emotional or behavioral, to these foods. And so you make up an excuse that you've got work to do and you're not able to make it. Again, in the short term, the anxiety will decrease. In the long term, it will get worse. And so then when you're out on a date and the person that you're with orders dessert at the restaurant, and there's this sort of, it would probably be normative for both of you to order dessert or for you to share a dessert, the likelihood is much greater, right? That you don't believe that you can tolerate the dessert. You're not supposed to eat dessert. It's going to lead to a binge eating episode. It's going to be very uncomfortable and embarrassing. And so the option that you take again is avoidance of that, not eating the dessert. And the truth of the matter is, in each of these situations, there is some effect on your life, on your quality of life, as you avoid these things. You know, avoidance, while it feels good in the short term, is not good for us in the long term. You're missing spending time with your family for your niece's birthday party. You're not connecting socially with friends from work, right? And you're out on a date with someone who is going to be, you know, somewhat cognizant or wary that there's significant anxiety for you around food, right? You're not going to get to share this thing with them. And so that's the pattern that we know exists for avoidance. And that you can all think of something, it may not be food, but something else that you avoid. We all have that stuff that we avoid. And we know that to avoid things in the moment makes us feel a little bit better. But that avoidance makes the next time we face that thing a little bit worse. So the idea behind exposures, could you help me go to the next? Thank you. The idea behind these exposures, just as Meg was describing, is that you have the experience, it's really learning that what we get down to really is that food is just food. You have these foods, they take on these powers, these beliefs, this strength, this influence. And by exposing people to the foods, they're just Oreos. This is what happens over time. So if the little arches here are sort of, you know, level of distress, it may be that first time, that first night of program, as Meg was describing, the idea of having dessert is terrifying. The fact that we're asking them to do it doesn't make any sense at all, right? And the anxiety goes way, 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 way up. And then because they're in program with us for another hour and a half, right, 2 hours, time will elapse and they will have the experience of that distress and anxiety go down, because that's what happens. We all have anxiety. It gets to a point, it doesn't go any higher, and then time elapses and that anxiety will come back down. And so our patients learn that that it was really anxiety provoking, that they did it, that the anxiety came back down, and because there's such a strong emotional component for so many of our patients in the binge eating behavior, they are less vulnerable to the binge eating because they're staying with us in program, they're managing some of those things. We have staff around to support them if they're having a hard time getting through it, right? But they learn over time that this is a food that they can control themselves around, right? They often learn that this is a food that they actually don't really like that much, or they don't really enjoy sometimes, or on the contrary, they learn that they can really enjoy the amount of dessert that we are serving for them and feel satisfied and great about that afterwards, right? So we have people have a lot of different reactions to this intervention, and what is, I think, most important for us is that they learn that they can tolerate whatever comes up around it. In a lot of cases, our patients, through their nutrition counseling and therapy, they also learn where a lot of their beliefs come from about these foods. And in some of them, it's previous experience. And for some people, it's the media and the way that the world, talks about these foods. For some people, it's, the conversations that just happen socially, everybody talking about what's good and what's bad, right? It's about challenging that black and white thinking. And so at the end of treatment, we may have worked through exposures to a number of different foods that are on this list, which has this strong black and white label, right? The bad foods and the unhealthy foods. And in the end, if we remove those good and bad labels and it's just food, it's going to be less of a big deal to sort of cut some of those foods out of their diet or to decrease the amount of those foods that they eat, right? The food just has less power. It will make it easier to follow recommendations that you guys are making pre and post surgery.
So what we're doing is we're just redistributing what's going on in the day. I've talked a little bit about those small breakfasts, those small lunches, and then the loss of control eating that occurs in the evening. And what we're trying to do is take that large amount and spread it out so that that hunger piece isn't driving the binging, and also they're getting skills to sit with uncomfortable emotions. What happens isn't always weight loss, and that can feel challenging for clients, that can feel challenging for medical teams that we work with at times. So framing that expectation can be helpful. Again, that idea of the pendulum, if we're not actively gaining weight, maybe we're not actively losing weight. Our goal is stability and to interrupt the binges and interrupt any upward trajectory that's going on. So again, having a breakfast, having a lunch, having a dinner, snacks between, but it doesn't mean like assessing what their nutrition needs are and specifically undercutting it, again, because that leaves them vulnerable to the binge behaviors. And what we want to do is interrupt that and have them feel comfortable and stable with their eating patterns before we move on. The other thing, as this connects a little bit to the exposure work that we were just talking about, is the belief of what exposure will do to bodies is something that's helpful for them to learn, doesn't get realized. So the worst case scenario is if I eat these Oreos, it's going to lead to an unacceptable change in my body, and that feels really scary. And so when we do this and we're stabilizing both behaviors and weight, the experience is like, oh, this isn't having this dramatic reaction. My body is able to handle this. And a couple of things that I talk about, I'm going to jump down a little bit to the goals. A couple of the things that I talk about in terms of the exposures and in terms of the structure and the setup of the eating pattern is eating competence. So how can we help our clients make decisions when it comes to food and have it feel like those decisions feel comfortable, competent, and confident? So coming back to that, the characteristic loss of control, we're not letting the black and white rigidity or the eating disorder determine what is getting eaten. The client is feeling much more capable of making those decisions for themselves, and that then feels better to engage in conversations around eating for the big picture or eating for the long term. So really shifting the center of decision making back to the client. So then, what do we do when the attention is on the weight a lot and we're in this pre-surgical phase? That can feel like, right, as dietitians, it feels like the microscope is on us. So if they're gaining weight, okay, we have to change the meal plan and make it smaller, smaller, smaller. Sometimes that's really hard to do. Sometimes those conversations get down to like, have 1 tablespoon of hummus instead of 2, and our clients are looking at us like, that makes that big of a difference. So it can feel like if we're chasing that carrot a little bit, it can be helpful to say, let's pause and see what's going on in the body. And this might be one of those things where maybe binge episodes are happening, and that's hard to talk about, and that might be why we're talking about the minutia of hummus, for example, versus the big picture of eating patterns overall. So it can be helpful to clarify with the team what the goal for weight loss is. So if you're feeling responsible for the weight trends and the weight patterns, bring it up to the team and see if you can have I know this is about relationships and how teams work together. So if you're feeling comfortable talking to the physician or the team that you're working with around, I think something else is going on here, can we decrease the urgency on the weight loss and increase the urgency on interrupting the eating disorder behaviors or interrupting the binging, because I think that'll have an impact. And then following any structure demonstrates adherence. So sometimes we're talking about meal plan compliance, sometimes we're talking about a client's ability to follow through with the treatment team's recommendations as an indicator for surgery. If we can follow a structured eating pattern, that can help build up evidence around that. Do you want this back?
Okay, so one of the things that we have recommended is potentially making referrals to eating disorder treatment program. I just wanted to run through real quickly the typical goals of those programs and some of the names or acronyms that you might hear thrown out by the behavioral health providers that you're working with. In general, what we're really aiming for, and I think that in some ways these align perfectly with the goals of the sort of bariatric team, is increased awareness of emotions, thoughts, and patterns of behavior around food. So, while not all of your patients have clinical eating disorders, right? Or they meet criteria for binge eating disorder, there's a level of disordered eating, right? And so understanding those patterns, understanding the emotions that underlie some of their urges or thoughts is gonna be really important. And we're always gonna be working towards increasing that awareness. In many cases, we're trying to help our patients identify the interpersonal patterns within their current relationships that tend to precede and perpetuate binge eating. In many cases, we're going to talk about values as they relate to weight, shape, and eating, and goals that they have around weight, shape, and eating. And then certainly we call ourselves a very sort of skills-based program. So one of the things that I did not mention that I should have is that for lots of patients struggling with binge eating, the behavior itself has come to be a means of managing emotional state. So that numbing that I described, the kind of zoning out, that is actually a brief break from reality, from life, from the world. And that feels pretty good in the short term. And so whether or not it sort of started that way, many of our patients report that the binge eating is a way of managing those distressing, difficult moments. And we want to help our patients gain other behaviors, other activities, other skills to help them manage all the things that life is currently throwing at them and all the challenges that are to come in their lives. And again, so we want to turn away from food as a primary coping mechanism to other behaviors. Right now, we have the most research evidence for cognitive behavioral therapy and interpersonal psychotherapy. There's a self-help and a therapist-supported guided self-help version of the cognitive behavioral therapy. But there's also a lot of really promising evidence for dialectical behavior therapy, acceptance and commitment therapy. These things, there's all these acronyms and therapies. They have a lot of things in common, truly. And I think that these sort of overall goals are very similar between them. So there may also be, part of the multidisciplinary team can often be a prescriber, and there's a number of different, medication options. Many of these are borrowed from other psychological or psychiatric problems. What I presented on the screen here are the medications for which we have the most evidence. There are certainly other medications being used and prescribed for binge eating. But within the antidepressant category, we know that Prozac's very effective in decreasing the frequency of binge eating episodes. Within actually the anticonvulsants, we know that Topamax can also be very helpful for patients to decrease frequency. And then Vyvanse, which is typically prescribed for attention deficit hyperactivity disorder, it actually has FDA approval for the treatment of binge eating. This is a pretty big deal for us in the eating disorder field because this is only the second medication to ever be FDA approved for an eating disorder. And I would say that Vyvanse is one of those medications that prescribers are pretty comfortable with and prescribing, even PCPs, right, for attention issues. And so we often see a lot of patients who are taking or who have tried one of these medications. And I think it's very possible for some patients that, sort of the different interventions work for different people. It might be that starting on a medication that decreases the frequency of binge eating increases readiness to engage in treatment, so certainly that is the case. I don't know anyone for whom they're going to be on these medications forever in the long term to treat binge eating disorder, but they can certainly kind of help get the ball rolling, and so we have a number of patients who do find that pretty helpful. So, you guys all work on multidisciplinary teams, and so Meg and I wanted to talk a little bit about, how to sort of navigate discussions of the presence of an eating disorder in the midst of the treatment team meetings that you guys might be having. So, I would say that, from my experience meeting with teams, usually there's the sort of medical end and with the physicians and nurses, and the nutrition end with the registered dietitians. Not as many teams have the behavioral health component. So we really do, you may or may not agree, but we would recommend seeking out and including behavioral health providers when you can. Certainly in the presence of binge eating, we definitely think it's going to be important and helpful, whether that is an outpatient individual therapist, whether that is an eating disorder treatment program and the providers in that program. Certainly this is going to help facilitate you guys getting patients who you're worried about or questioning into more intensive eating disorder treatment. So releases to sort of speak with and communicate with the outpatient team. Eating disorder providers are very familiar with and comfortable collaborating. This is something that we have to do all the time with all eating disorder diagnoses, and we are very invested and engaged in collaborating with bariatric surgery teams as well. So making sure that there is sort of open dialogue and a release so that we can all communicate together is going to be really important. We also, we recognize that if you do not have behavioral health on your team, it may be necessary and important for you guys to seek consultation. You have our phone numbers or email addresses at the end of this. You are welcome to consult with us, with Meg and I, about patients who you're a little bit worried about or who you're wondering whether or not they might benefit from some sort of additional treatment. But in general, if the setting that you work in has a behavioral health department, pick the brain of one of those providers. If there are dietitians on your teams who have been working with bariatric surgery for longer, consult with them. It's going to happen that you guys are going to have patients who you're not sure whether or not there is sort of a binge eating or loss of control eating component. And this, again, like Meg said, it's a newer disorder. This has not been around forever. Your patients may be using any of those labels to describe their eating episodes, right? And I think that we really want to encourage that. It makes a lot of sense to consult. It's going to be very helpful to both you and your patients to involve consultation. And the likelihood, we just imagine that in a multidisciplinary team meeting, this stuff's going to come up. It's going to be part of the decision around readiness. It's going to be part of the decision around progress. So we highly recommend it.
So we also work with clients, or I also see clients who have had surgery and experience the emergence of either binge eating or loss of control eating. Again, because after surgery, the ability to eat what was objectively considered a large quantity might be shifted because of anatomical constraints. But there's still that sense of loss of control. We also can see symptom shifting. So sometimes the inability to achieve that kind of numbing or pause from the distress of life can shift things into restriction or purging episodes. So it's just helpful to be aware that that can happen. The fear of fatness and weight regain. So once we've had a client lose the weight, and then there's a little bit of a window, around 2 years, where weight regain is really common, and that can feel really vulnerable, and it can feel terrifying for our clients. So having our antenna up around these vulnerable timelines for either increased restriction or the return of some of the eating disorder behaviors through loss of control eating. And I have worked with clients who've needed more intensive treatment at that point. So we have a residential and an inpatient program, and sometimes the medical stability. So weight loss over the last 2 years and then increased restriction. We're talking about really frank and severe malnutrition at times, and more intense levels of care have been needed. So 2 years after surgery, is Sue Cummings here, I think? I think she's talking later, not late in the day? Okay, so I heard her talk at the Massachusetts Dietetic Association meeting, and it was really interesting to hear her talk about this 2-year timeline, because we also see that 2-year timeline. So you're gonna get, I'm super glad that you're gonna get that slice of it too. It can be tough, and we'll see clients, so we're right here at the stairway. We can see clients where stomach size determines meal size. There has been shifts to the anatomy, and we really need to accommodate that. So in terms of what an eating pattern looks like after surgery, the client's comfort determines it. I don't know what their anatomy looks like, and I'm really relying on them to be a little bit more of an expert in their own body and experience around. It's not always appropriate to recommend those ranges that you saw in the meal plan earlier in terms of frank volume. And so being mindful of that. We're still wanting to have that structure of multiple food groups present, eating throughout the day, but sometimes that looks like a very different portion size. Adjustments to the eating pattern. The pattern that I've seen most often is that the fear of introducing some of the challenge foods is that I'll experience dumping syndrome afterwards. That tends to be less of an issue a year out and after a year out, so they're at less risk for dumping. But what I like to frame that as a conversation is their own experience of their body. So if they're eating foods in loss of control episodes that they're fearful of, how has their body responded historically in the interval since surgery? So that's an area where, again, we can do a lot of information gathering about their lived experience and their body's response to those foods. In terms of my personal experience, I've had a lot of clients not experience dumping syndrome with the introduction of those challenge foods with some distance from surgery, but this is an area where an individual's response is going to be very individualized, hard to predict. It's not like one pattern fits all, so we really want to be listening to their experience. And then separating fluids from meals. So I've had clients that have this be a challenge because they're fearful that having fluids and solid meals together is going to expand their stomach. So it's that the concern is rooted in that fear of weight regain, and it can be really hard to meet hydration needs when we're talking about the timing and the spacing of meals. So keeping an eye on that, and then challenging that when it feels appropriate. I've collaborated with outpatient bariatric dietitians in the past who've been like, they're okay to combine meals and beverages, and so having that come from both of us together has really helped support a patient in shifting those times and those patterns. But those are real considerations, and not every client is going to either be physically comfortable combining those two things. So again, we want to be mindful that the recommendations are individualized. And then 5 or 10 years after surgery, this is where I start to see portion sizes start to shift. It's almost as if the surgery didn't happen. So a lot of people are feeling like my comfort with portions is back up to where it used to be, or the anatomical changes aren't determining the amount or the quantities that I'm eating, either in a binge or at meals. So therefore, we want the meal plan and the treatment approach to respond to where their body is. And that can look a little bit more like the pre-surgical treatment plan and intervention plan. But it's, again, there's nothing special about like 5 years, there's nothing special about 10 years. It's always evaluating where their body is and where their behaviors are and responding to the best of our ability and listening to their experiences and responses. So I describe the eating pattern, that structured eating plan, as being one place on a continuum of tools. Over here on what's my right and your left is a lot of structure and support, and over on this side we have a lot of body listening, body trust, body confidence. So on the far side of structure and support would be something like enteral nutrition, plated meals, where what's decided in the portions are presented and decided ahead of time, or meal replacement. So those are the things like the shakes, or what we call supplements, so like the Boost, the Ensure, the Glucina, Glucerna. In the middle, but more on the side of structure and support, are those exchange-based meal plans. That's what we use in program, and I find that it's helpful to kind of cut through that question of like, where do I even start? Where do I even begin? And it's enough structure that we can then loosen it up and add more flexibility based on how people feel after a day or a week or so, giving it a try, or we can add more structure based on how overwhelming that feels. So it's kind of a middle ground, and we can toggle either way. Has anyone heard of the rule of threes? Some? Okay. So it's a tool that we use in eating disorder nutrition, and it's a way of saying, if you need the support of a dietitian to help decide what exchanges and portions should look like through an exchange-based meal plan, and you've done that for a little bit of time, and you're ready to start making those decisions without feeling like, oh my goodness, I have to check my meal plan, or I have to get my measuring cups out, right? Because measuring cups can feel really diety, or it can feel really vulnerable to past situations that don't feel like they worked in the past. Wanting to not have that be hampering and hemmed in, but being like, okay, let's start taking those steps. Let's shift more of the decision making over to you. That's where the rule of threes comes in. It's like 3 meals a day, snacks between meals, the 3 major food groups, which I call the 3 major food groups, the starches, the proteins, the fats. Whenever I talk about this, I always expand it to my 5-finger plan. So starches, fats, proteins, fruits and vegetables, and fluids are the 5 components. I'm like, if you're walking through a cafeteria with a tray and you can check off those 5 components, you're pretty solidly there in terms of like meeting your meal plan exchanges. We're just talking a little bit about differences in quantity. And then intuitive and mindful eating. How many people have heard about intuitive and mindful eating? Yeah, they're 2 different concepts, so I don't want to bundle them in, but they're both concepts that rely a little bit on that idea of competence, confidence, and body trust. They are awesome tools, and they are hard to start integrating right off of the bat. So when a patient is so fearful or learning about their body's responses to surgery, or feeling like they can't trust their body to respond to the food that they're eating in a way that I'm confident it will, or I'm talking about it will. Again, that idea of the Oreos, if I eat Oreos, I'm like, this unacceptable change is going to happen. It can be hard to say, eat what you want when you want it, eat when you're hungry, stop when you're full, if we're still learning hunger and fullness cues. So that's why sometimes intuitive eating, I think, is like the conceptual concept of what eating disorder recovery nutrition looks like. And don't get me wrong, I love it, it's a really helpful tool. For the amount of anxiety that we're talking about, or how difficult it is to start exploring what is my body asking for and how does my body feel, it can be putting the cart before the horse, so to speak. So again, we're talking about skill building. We're talking about starting from structure and building from there. But I did want to mention it in case you had heard of intuitive eating, and we're like, that's what it looks like. It's a tool. I like it. But it's a skill, and we need to build towards it, because it can feel like jumping into the deep end sometimes without enough support.
So we have honestly touched on many of these. We can't say enough about the role of shame and guilt with someone experiencing binge eating or loss of control eating. It can lead to underreporting, minimizing, or denying of different behaviors when they're sitting in an office with you. I think that it likely leads to canceling or missing appointments. One of the things that I'm always sure to talk about in the context of the pre-surgery psychosocial eval is that, you know, there's going to be times when you struggle after surgery. There is going to be some point at which your weight loss will plateau. Unfortunately, a lot of people stop following up with their team at that point because of these feelings of shame or guilt, or the burden that they take on about them doing something wrong. And I was like, just so you know, we actually think that that's exactly the time that you need to keep following up with your team. So trying to kind of normalize the shame, normalize the guilt, make space for it is going to be really important. And a couple things we just wanted to mention about the stigma that we all carry around with ourselves. I think that we are absolutely still understanding the mechanisms by which, you know, bariatric surgery works and is effective, and who it seems to work better for and not so well for. And so I think that sometimes we experience doubts about what our patients are telling us is actually going on when we're not sitting with them in session. When it comes to their food or when it comes to their choices, we might have our own frustration about progress with this. And again, like, especially with binge eating, this is a population that's already highly self-critical and feeling like they are not efficacious. And so we just need to be mindful of the way in which our own stigma or beliefs about how this whole thing works can affect our patients and affect their comfort with us and affect their likelihood to report what's really going on. And I think that the other piece that happens is that sometimes when when weight loss plateaus or when weight regain happens, there's really a lot of blaming of the patient versus, the procedure or their biology, which they don't have any control over. And so we just have to be a little bit mindful of that when working with this population. I'm going to fly through our Walden Behavioral Care's programming and system of care. We are lucky to have a full spectrum from the inpatient level of care through outpatient. These arrows are going in one way, but in cases where patients need more structure, we also kind of send people to different levels. They may start in our intensive outpatient, step up to a day treatment program in partial, and then come back. We have locations all across Massachusetts and Connecticut, and recently Georgia. The clinics provide the intensive outpatient and the partial hospitalization or day treatment programming. And then we have a residential program and an inpatient program in Waltham. And we also have an inpatient program in Connecticut at Rockville Hospital in Vernon, Connecticut. And then we also have a residential program down in Georgia in our Dunwoody location. So we're going to treat binge eating disorder at every single level of care, but it's most common, and especially for the patients you guys would be working with, for them to step into our Free to Be program designed specifically for adults struggling with binge eating. This is a specialized program. They get access to a therapist and a dietitian. We find that we get a lot of positive feedback about this program. And the bariatric track, which we build individually for any patient who is, pre or post surgery, is set within that Free to Be program. So we essentially sort of tailor a treatment plan to pull the aspects from that program that we think would be most helpful for them as they prepare for or post surgery. So thanks so much. Again, really, truly, call us, email us, ask us questions. Meg and I would love to support you guys if you have patients that you're working with that you have any concerns about.
And thank you so much for having us.
Thank you. So we would love questions if you have any. We don't have a lot of time left. Okay. Great.
Do you find that people who are binge eaters beforehand are more likely to abuse alcohol after, if they've kind of controlled the binge eating?
More likely to use alcohol?
To abuse it after?
So while the behaviors have that same impulsive feel to them, we don't actually have data that links binge eating to being at increased risk of substance use. Obviously, there's a lot of data now that substance use is likely to come up post-surgery, that there's a higher risk for that. I think intuitively, I completely agree with you, and that makes sense. I don't know of any research that says that specifically.
I'm not a dietitian, but I am very grateful for your presentation, followed by the previous presentation at the New England Metabolic and Bariatric Society. I don't know if anyone's a member, but at the inaugural meeting, Lee Kaplan from MGH presented an amazing amount of data that is indicating, and this is more of a pre-surgical comment, that the more we try to get a patient to lose weight before surgery, the more likely we're going to increase binge eating behavior. And there's a movement right now to challenge the insurance companies to remove the preoperative weight loss and just focus on the liver shrinking if that is indeed necessary for the surgery. So I think that's pretty important for us to look at as teams, as treatment teams, that the preoperative dieting can really play a big role in this. And to answer your question about alcohol, I think from a psychosocial standpoint, when we're looking at that preoperative evaluation, someone who tends to be a little on the lonely side or shy or some of those kind of qualities, once they start going out and feeling a lot better, that tends to be predictive of some of the alcohol. There's not great data on that. I agree with you there, but it's something clinically that we can look for sure. Yeah.
Thank you.
I have a two-part question. So you had how do you feel about, at the same time being in treatment for binge eating disorder and then seeing a dietitian, the collaboration about pre-op, how important that is? And then the second part is, when do you feel that the person would be cleared to go forth and have surgery in the pre-op phase dealing with binge eating disorder?
I can talk a little bit to the dietitian relationship pre-surgery. One is, I think it's so important. I think clinical collaboration for all treatment teams, like across all treatment members, is important, but especially for the dietitians, for there to be an understanding of like why I'm making the recommendations I'm making. Because the client has that thought, like, why are you telling me to have the challenge foods? Why are you telling me to have the dessert? Why are you telling me to have snacks? These are some of the things that a pre-surgical eating pattern might target or exclude. And then if we identify that binge behaviors are going on, to return them intentionally feels very challenging. I think that it's essential that the dietitians communicate to do the work of resolving that tension so that the client is not left holding conflicting messages and being like, how do I synthesize this? Because that's a lot to ask of them when we could be taking some of that on ourselves. Part of what I wanted to do is illustrate like why I'm making the recommendations and the effect that it has. It is helpful. Like I don't make these recommendations in a vacuum. I see clients make these changes, come in terrified to make the changes, and have it be successful in helping them interrupt the eating disorder patterns. So being on the same page around what the recommendations are and permission to eat at times can be helpful for both parties to give. And then so that it's not me working in a vacuum, I'm understanding what their big picture goals are, what their long-term picture goals are, because I'm not their outpatient dietitian. I'm not following them up for years and years and years. I think one of the recommendations, and like a little nugget that might be helpful, is if we're working with someone, can we increase the frequency of visits so that those conversations around understanding what's going on can be had in a more comprehensive way. Like that's an idea that we can bring to our treatment teams if we're feeling stuck, and that like they're meeting with me really frequently, and then to have that like be an abrupt shift all of a sudden can be tough. But yep, I think communication is helpful for being on the same page and then helping for a smooth transition.
And I guess I'll just answer the second part of your question, and then we have to wrap things up. So if anybody else has more questions, please do approach us. In general, I think that as I kind of mentioned, we're not going to make the call, and a mental health provider who is making recommendations isn't necessarily going to say this person is not appropriate for surgery because of the binge eating disorder. And so the clearance question has a lot more to do with, I think, collaboration with the team and talking with the team about the changes that the patient has made in the context of treatment, the increased awareness. And a lot of times it's similar to the goal of the psychosocial eval, where in the context of treatment, you're going to identify the patterns, the thoughts, the things to even look out for post-surgery. We want to make sure that the team has all that information as well. We want to potentially connect them. Sometimes we're making referrals to a behavioral health provider who can continue to work with them through the surgery and post to be able to kind of keep an eye on some of those things. But we don't have a exact kind of data on making that recommendation about readiness, because we don't have exact data that it's necessarily going to compromise outcomes post-surgery. Thank you.